project from Canada, India, China, and South Africa. This is a pre-pregnancy cohort. It is still ongoing. For those who are really keen for accessing data, want to work with the longitudinal data set, Kumaran would be more than pleased if you approach him, go and meet him, and learn about the cohort and the other cohorts that has been available locally. Over to you, Kumaran. Thank you for agreeing to come at a short notice too. Thank you.
Thanks very much. It's a pleasure to be here. And thanks to the organizers for asking me to be here, particularly Sarah and Rahul. Sarah got in touch with me a couple of weeks ago to say, there's this meeting here about machine learning and health. Can you do a talk? And I said, I don't know anything about machine learning or AI. And he said, I know that, but we want you to come and talk about healthy and look at the potential collaborations that can be considered. So what I'm going to do today is give you an overview of the study called Healthy, the Healthy Life Trajectories Initiative. As Sarah mentioned, it's a collaborative study across 4 countries, India, China, South Africa, and Canada. So I'm going to give a little bit about the background of the study, how it started, the setting up of the consortium and the complexities involved in that, how we started implementing the study locally in rural Mysore, something about the challenges we have faced, both as a consortium and locally, and then finally, just briefly look at some of the opportunities that exist for future collaboration. So Healthy is based on the programming or the fetal origins hypothesis or the developmental origins of health and disease, as it's now called. And I think Sarah touched upon the intergenerational programming of non-communicable diseases earlier in his talk. So this is essentially based on the work of David Barker, who many years ago suggested that transient environmental insults during critical stages of development have permanent long-term effects. And he sort of came up with this when he was looking at data based on ecological studies. So he found that coronary heart disease death rates in the UK in the 1970s were high, and that mapped with the local authorities that had high death rates from neonatal mortality in the 1910s. So this started off the work in the UK, where he then moved on to studies on individuals, showed that individuals who were born with lower birth weight, there was no cutoff, it was just lower, as in a continuous form, were more likely to develop type 2 diabetes and coronary heart disease in their 60s and 70s. And this work then moved on to other parts of the world, including Europe, North America, as well as India. So we were involved in some of the first studies in India, looking at the fetal origins, where we showed that poor maternal nutrition, lower birth weight, poor growth in infancy, as well as accelerated growth, particularly during childhood and adolescence, were all associated with a higher risk of developing non-communicable diseases later on. So this was, so the discussion for Healthy essentially goes back to the World DOHAD Congress. There's a World DOHAD Congress that takes place every 2 years. And in the 2013 one in Singapore, there was a lot of discussion about non-communicable diseases being a major challenge and the biggest challenge we're likely to face in the 21st century. Just some data that shows the huge number of people who die prematurely between the ages of 30 and 69 each year, and how much of this could potentially be prevented. And then we had the Ending Childhood Obesity, or the ECHO report, which was presented to the WHO. And this identified childhood obesity as a major public health problem, and also the way we could tackle it. So there were 6 key areas of action, one of which was addressing the preconceptional period, i.e., even before women became pregnant, because obesity has intergenerational transmission. So that was one of the key findings from that report. A recommendation was made to promote collaborative research on this field, and Healthy was officially launched in the 2015 DOHAD Congress in Cape Town. So the idea behind Healthy was that the first 1,000 days may not really be enough. So starting in pregnancy, starting interventions in pregnancy may not be enough because they miss the sort of important events that occur around the periconceptual area, including gametogenesis, the early development periods, but as well as the women approaching pregnancy with appropriate health. And then there was also some evidence to show that single interventions themselves have only modest impact. So the idea was to try and look at a more complete or a more complex type of intervention and carry it out longitudinally. So the overarching question was, will the health of women before and during pregnancy predispose infants to overweight, obesity in childhood and the future risk of NCD? And if yes, can this be modified? Because this has significant implications for both public health practice and future policy. So the idea was to look at an integrated evidence starting preconceptionally, continuing through pregnancy and into infancy and early childhood. And the idea was to see whether this would reduce adiposity or childhood obesity, improve neurodevelopment in the children, as well as parental and pregnancy outcomes. So the consortium was formed in 2014, and the idea behind 4 research groups in 4 countries getting together was essentially to increase value. So 4 research groups addressing the same questions in different settings. A long time, I mean, the funders have been quite far-sighted. So this is funded by the Canadian Institutes of Health Research, the Department of Biotechnology in India, the National Science Foundation of China, and the South African Medical Research Council in collaboration with the WHO. And the funders have been quite far-sighted in that these have been funded as 10-year projects, which is very, very unusual in health research, so that we could go up to child outcomes in terms of timeline. And then there was a lot of focus on harmonizing these 4 studies at the beginning itself, because it's become very difficult to pool data if you don't harmonize everything beforehand. You know, post hoc study harmonizations doesn't really work. So the overarching aims was to evaluate a multifaceted intervention, conduct mechanistic studies so that we could understand causes. And when I talk about the range of biospecimens we are collecting, you can see the potential for mechanistic studies. So develop cross-country collaborations to foster learning and to promote capacity development, particularly younger researchers, and then use this to guide policy and practice. So these are the 4 sites. These sites are in countries who are in different stages of transition. So we have 2 sites in Canada, which is a high-income setting. We have Shanghai in China, fairly advanced on the pathway to transition. We have Soweto in South Africa, which has made rapid progress in transition in the last 10 or 15 years. And then we have rural Mysore, where transition is just beginning, but where we could potentially have a huge impact if we are able to mitigate some of the effects of transition. And so we expect to recruit over 20,000 women across the sites and hopefully end up with over 10,000 pregnancies. So this is the team, and that wordle there just shows the expertise we have within the teams. So across the 4 countries, we have over 120 investigators from 35 institutes. So there's a lot of expertise within the teams. And we have a central office that's based in Canada. We have a common data safety monitoring board that oversees all 4 studies. We have 7 different working groups that, again, across the 4 teams that sort of agree SOPs, protocols, good practices. So for example, we have groups on biospecimens, we have groups on data management, we have groups on intervention development, groups on fidelity, et cetera, et cetera. So these are the study designs for the 4 sites. So each site will recruit between 4.5 and about 6,000 participants. India and China have a cluster design, whereas South Africa and Canada will have an individual study design. So where the participants are randomized individually, whereas in India and China, we're going to randomize clusters. So in India, the unit of cluster is a village. So all the studies are adequately powered to detect a primary outcome, which is adiposity at 5 years of age. So between 80 and 90% power. And The interventions will be delivered by community health workers in South Africa and India, but by trained nurses in China and and Canada. So when we started developing the intervention, we had to think about the balance that we could achieve between something that was ideal and something that was pragmatic. So we had to make a lot of decisions about, what did we want to focus on? Should it be more structural intervention? Should it be based on individual intervention? How harmonized should it be? How site specific should it be? Do we make it too complex and then end up finding it's not scalable? Do we focus on underweight, which is a major issue in India, or overweight and obesity, which are major factors in China and South Africa? So all of these were factors that we had to consider while we were trying to harmonize the domains of intervention. And also, what was our main outcome focus going to be? Was it going to be child development, or was it going to be metabolic fitness? So we then started developing the interventions using the MRC guidelines for development and evaluation of complex interventions. So we used the ECHO report, of course, which was the basis for Healthy being set up, evidence, extensive formative and pilot work. And so this was the sort of cycle we followed. We looked at development, then piloted it, evaluated it, implemented it, and then came back and did this circle again. So the intervention, we developed it over 4 phases. There will be a suite of interventions that start before the women become pregnant, i.e. in the preconception phase. Then there's an addition of interventions in the pregnancy phase, the infancy phase, which is 0 to 2 years, and then finally the childhood phase, which is 3 to 5 years. So the domains of intervention, although the way the interventions are delivered in each site will be different because of the local context and socio-cultural circumstances, we decided to harmonize on common domains. So the domains were to optimize health, to optimize nutrition, to promote child development, and to optimize mental health. So these are the site interventions across the 4 sites. So when we looked at optimizing nutrition, all the 4 sites have got interventions that will optimize maternal BMI before pregnancy, optimize micronutrient status. So although optimize micronutrient, so for optimizing micronutrient status is a domain that all 4 teams will address. But the way we do it will be site specific. So in China and Canada, it will be done through diet and routine practices, whereas in India and South Africa, we are specifically providing the women with multiple micronutrient supplements. So each of the interventions, although the domains are same, the way we deliver them will be site specific. And so there are interventions for child development to support parents and develop parenting skills, to promote a suitable childhood environment at home, optimizing physical and mental health, and the home environment. So for example, under optimizing home environment, in India, we're trying to focus on reducing indoor smoke exposure, particularly exposure to cigarette smoke indoors and to smoke from cooking fuels. Optimizing environment in South Africa has a completely different context. So that relates more to domestic abuse. So each of these interventions, the way they are delivered, are site specific. So we are planning to collect a range of measures in the women, their spouses or the fathers, and then the child. And it includes physical measures, socio-demographic measurements, something around attitudes, lifestyle behaviors, as well as physical and mental health. And this just shows the data collection points that we have. We've got a total of 10 data collection points starting from baseline until the child reaches 5 years of age. And there's a lot of harmonization that has gone on to ensure that we collect data in a similar manner using common tools wherever possible. So, and each of the sites are doing at least 8 of these collection rounds out of 10. So we will have a lot of data across 4 sites, which will be hugely harmonized. We've got a total of about 1,800 odd variables, out of which 1,300 variables have actually been harmonized across the sites. So a lot of work has been done on this process of harmonization. We're using a system called Maelstrom, which is at McGill University in Canada. So who've been helping us with the harmonization of the a data collection from each of the sites. And so that has a catalog of all the variables that we are collecting on, so you can go onto the Maelstrom site and just check which of the variables have been harmonized and which of the variables haven't been harmonized, and what kind of data might or might not be collected. So in terms of outcomes, our primary outcome is adiposity at 5 years of age, and we are measuring that with DEXA, dual X-ray absorptiometry. So we measure fat mass, and then the measure of adiposity we are using is fat mass index, which is fat mass divided by height squared. And then we have a host of secondary outcomes, which include anthropometry starting from birth, linear growth up to 5 years of age, measures of stunting, cardiometabolic outcomes such as blood pressure, glucose, health behaviors, mental health, school readiness, and similarly with the mother. So the volume of data when we finally finish the study is going to be enormous. And I think this is where we have a lot of potential to learn from newer computational techniques. The analysis itself, we had a lot of debate about this when we started the study, because if you look at a classical randomized controlled trial, you don't analyze the data by groups until you reach the primary outcome. But with Healthy being such a long-term study, we didn't really think that was going to be feasible. So we then went through a full-blown consultation exercise where we consulted experts in various fields from around the world. And then we finally made a decision that we would analyze this data at the end of each phase. So for example, at the end of the preconceptional phase, we can analyze some data looking at nutrition and health behaviors. And we'll do that once all the women have crossed the preconception stage and moved into the pregnancy phase. So that's when we will start unblinding. Similarly, in the pregnancy phase, we can look at things like gestational diabetes mellitus, gestational hypertension, preterm births, etc., etc. And again, we can do that once all of the women have crossed the pregnancy phase and have delivered babies. So that's the way we are actually planning to analyze this data. And there were a variety of reasons why we actually took this approach rather than adopt the purest approach of waiting until the primary outcome is reached. We have a lot of investigators who have invested time, effort into the study. We can't expect everyone, including postdoc students and PhD students, to wait until 10 years to start looking at data and publishing papers. And we also felt all of this would not affect our primary outcome mainly. So that was the kind of approach we took. And the consultation exercise included experts in statistics, experts in clinical trials, experts in Dohad science, bioethics. So we consulted a range of people before we actually came to this conclusion. So I've spoken a bit about harmonization already. All of the sites are using a technique called healthy conversation skills as the main behavior change agent to communicate with participants. Healthy conversation skills was developed by our colleagues in Southampton and has since been translated to other low and middle income country settings, including India. And so this is a method of conversation or engaging with participants so that participants make choices. It's not just about us telling them what to do. It's about us discussing with them and they deciding what is appropriate for them considering their own setting. The data collection and the management, we've got external experts from Maelstrom at McGill University. And the training and the quality assurance, all the sites have undergone training and quality monitoring from a similar group, which is led by the WHO. And so the WHO has been providing us training and supervision on growth and blood pressure. And for biospecimens, Donna Russell and her group, who are based in the US. So what are the biospecimens we are collecting? We're collecting a range of biospecimens, which includes blood, urine, cord blood and placenta, buccal swabs, breast milk, rectal swabs, sperm, etc., etc. And these are being collected longitudinally from the mother. So we have collection points preconceptionally, twice during pregnancy, and then post-pregnancy until 5 years of age. There's going to be data on the infants or the children, the fathers, and in Canada, they are also collecting data on the siblings. We expect to have a huge biorepository. So each site is expected to have over 500,000 samples, aliquots. And in India alone, we're going to have over 125,000 aliquots just for the preconception phase. So the biospecimen working group, which I mentioned earlier, which includes members from all the 4 country sites, have actually been working together on standardizing SOPs for collection, processing, so that we are all following similar techniques, and hopefully the data will be comparable. So the key thing is that all the blood samples are centrifuged within 30 minutes of draw, and then frozen. So in the field, we put them in dry ice, bring them back to the hospitals, and then put them in our -80 freezers. Don't worry about the detail of this slide, but this spreadsheet just shows the biospecimens that we're going to collect starting from baseline in each of the sites through pregnancy and then postnatally. So what is the learning we have had? So this is across the sites. Each of the sites has undertaken extensive formative work over an 18 to 24-month period. So each site has engaged with the local communities, their participants, their local health systems, and undertaken a mixture of qualitative work as well as quantitative work. The harmonization was a big learning point for us. And based on the formative work that each of us have undertaken, we were able to identify our priorities and challenges, and that helped us to guide intervention. But what we realized was that the context was crucial. So the context in India is very different to the context in South Africa, which is very different to the context in China. So each of us have had to adapt our interventions, our approaches to our local sites. So I'm now going to talk about how we actually went about developing the Indian arm of the study. So our study is called Einstein, Early Interventions to Support Trajectories for Healthy Life in India. And this name was thought of by one of our collaborators in Canada, Prakash. So we thought it was very appropriate because some of us were interested in child development. And so we thought Einstein might be a good one. So our study is set in rural Mysore. It's set in number of villages in rural Mysore. So what you see in this gap, all this green area is forest area. This is our main field site, the Vivekananda Memorial Hospital in Sargur. And there are 280 villages in this area, out of which we've selected 105 villages. The selection of the villages per se is not random. It's based on the size of the villages. So we have selected villages with a population of 1,000 and over. Because otherwise the sample size would not have worked for us. So we engaged with the local community to develop the intervention and plan our methods. And we undertook extensive formative work, which I'll come to. So as I said before, ours is a cluster-based study. So the villages form the unit of the cluster. We are recruiting married women over the age of 18. And we stuck to 18 mainly to get away with the legal issues. With no child or one child and who intend to have a child within the next couple of years, we've divided these villages randomly into 3 arms. And all recruitment takes place at the start of the study. And then, so the first arm receives the intervention starting preconceptionally. It continues through pregnancy and into postnatal life. The second arm receives the same suite of interventions, but the interventions start once the woman is diagnosed to be pregnant, and then continues through to postnatal life. So in practice, this is around the end of the first trimester. And the reason we wanted to include this specifically, only India has this third arm. All the other sites only have a preconception arm versus a control arm, and the arm 3 is the control arm. And the reason we wanted to specifically include a second arm where the intervention started in pregnancy was to be able to compare the relative costs and benefits of starting an intervention preconceptionally versus starting it in pregnancy. Obviously, starting an intervention preconceptionally is going to have resource implications. It's going to be a lot more expensive. It's going to be a lot more complex delivering it. Preconceptional interventions are not easy. They take time. It takes a lot of logistics, and managing it in the field is far more complex. So we thought if we are going to promote a preconception intervention, we need to make sure that it really is better and cost effective when compared to a pregnancy intervention. So this was the approach that we took. Our approach was based on the DOHAD science, the formative work we had undertaken, considering the local context, as well as the strength of the local teams. And so this is our setting. This is basically a rural population where transition has just started. So you can see these shops now cropping up in even the smaller villages where they're selling fried food, fizzy drinks, etc. They have very limited access to specialist health services. Our field site hospital is one of the 2 hospitals which covers a population of nearly 400,000 people, 4 lakh people who get care there. And these are basically at the level of district general hospitals. They don't have super specialty services. Their population is heavily dependent on subsistence farming. A lot of them don't own their land. They actually work as laborers in somebody else's land. Low levels of literacy, just about 50%, particularly among women. And among women, there's a high prevalence of not just underweight and anemia, but also overweight. So transition has started. And I'll show you some of our own data from the formative work, which will support that. But with the children, particularly in those under 5, they have high rates of anemia, almost 60%, and 38% of both stunting and underweight. So quite high levels of undernutrition. So this is the team. We have a number of centers across India. And although the study is based in Mysore, we have collaborators from different parts of India who either provide intellectual input or where the samples go for analysis. We have a list of collaborators from Canada and the UK. And these are the 2 field sites which have had extensive experience of working in the local community for the past 30, 40 years. So that is a big strength of our team in the sense that we've been working with the local communities, and that helps with a long-term study such as this. So we undertook the formative work in representative villages, and the aim really was to adopt the intervention to the needs of the local population. What are their priorities? What do they need, rather than just us thinking this is what they need and then doing it to them. So we had to make sure the approach was acceptable, but also feasible. And so what we did was we first held community engagement meetings, and we held this in each of the villages. And we got a mixture of the community leaders, the elders, the local women, all of them attended to explain the study to them and get their buy-in for the study. By and large, the people were very supportive. And what was humbling for us as researchers was that their motivations for participating were essentially unselfish. They wanted to participate because they felt it would help their children and grandchildren. But also they liked the idea that something that was being done in their villages could actually be scaled up to a state level or a national level. So Google Maps, of course, don't work in that area. So to identify where we had our eligible participants, our field workers essentially had hand-drawn maps of the areas that they went to. So we have a map for each of the 105 villages with where we had eligible participants actually being marked on this map. So we've surveyed over 140,000 people. We collected some additional information on their socioeconomic status and fuel. And this helped us identify close to the sample size that we'll actually need. So we held a number of focus group discussions with the village women, the families, the husbands, the mothers-in-law, the local healthcare staff, as well as the community leaders, the village elders, the local Zilla Parishad members. And this was to get their perspectives on the challenges, what was important to them, what could be done to improve health, their aspirations, etc., etc. And this helped us identify a number of issues. They were talking about how their diets had changed over the years, the socioeconomic changes, the increased use of pesticides, the lower levels of physical activity, and all of which helped us in guiding the development of our intervention modules. We undertook some quantitative work as well. So we did basic anthropometry. We took bloods to establish their nutritional status, and we collected information on their habits, including dietary habits, which helped us to modify our existing food frequency questionnaires. And And some of the key findings from that, their diets are mostly carbohydrates based. So for those who are not familiar with the local area, this is a ball of ragi. So ragi is the staple diet here, which they usually have with some very thin liquid. There's very little dal in it. It's mostly spices with a few vegetables and very little lentils. So their diets are mostly carbohydrate based. It lacks dietary diversity, low intake of micronutrient rich foods. And then our anthropometry and blood results showed supported existing literature. They had high levels of anemia and underweight in the women. But what was surprising was the rates of overweight and obesity. So data suggested about 20% were overweight. We found 27% overweight and 8% frankly obese. And we are talking international cutoffs here, BMI of 25 and a BMI of 30. So it does confirm that the double burden of malnutrition has actually started even in this rural area. So we developed intervention modules, which are delivered by local community health workers. They've been trained in this. And we used local community health workers who are essentially at the same level as the ASHA or the Anganwadi workers, so that if this proves successful, then scaling up hopefully should not be a major hassle. So we developed 6 modules preconceptionally, which focus on various areas such as general health, diet and nutrition, physical activity, mental health, hygiene, etc. 10 modules which are delivered during pregnancy and postnatally. Now, this is adapted from a program called Learning Through Play Plus, which was originally.
Interventions were provided all the hour?
No, the interventions are provided. The interventions are provided to the preconceptional arm. So the arm 1, where the interventions start before pregnancy. The second arm, the pregnancy arm, will get the same interventions after we diagnose pregnancy. And the third arm is the control arm. They get standard of care. They get slightly more than standard of care because standard of care preconceptionally is nothing. That's right. It starts preconceptionally through pregnancy and postnatally as well. And the arm 2 starts in pregnancy and continues postnatally. So learning through play starts in pregnancy and continues postnatally. This is an intervention that was originally developed in Pakistan by our collaborator Nusrat Hussain from Manchester. And it has since been translated to many other settings, including India. Vikram Patel's group in Goa did a large study using this. And this essentially is a module that aims to reduce antenatal and postnatal depression in the mother, promotes parenting skills, and consequently child development. So this starts in late pregnancy and continues until about 3 years of age. The team is now developing an intervention that can be used between 3 and 6 years of age, which we are planning to adapt once that is done. Based on the formative work, we also realized that the husbands are actually quite interested in their wife's health. That was unexpected for us. We didn't expect the husbands in this rural area to be so involved, but what we realized was they were actually involved. They wanted to get involved, but they were just shy because of cultural norms to actually come out with it. So the formative work helped us identify that, and we ended up developing 2 modules focused on their husbands. One on how they can look after themselves and their own health, and the second one is how they can actually support their wives during pregnancy. And these are done as short sessions in small groups with there's less of information imparting in this. There is some information shared, of course, but it's mostly like a discussion group, and where we get the women to make choices based on what they feel is feasible within their own settings. So this is the summary of our intervention. So preconceptionally, there's a focus on nutrition. India and South Africa give micronutrient supplements, but then the rest of the nutritional intervention is focusing on diet diversity and quality, how to avoid pollution exposure, hygiene promotion, these modules which are essentially underpinned by behavior change. And then postnatally, it's the parenting and child development intervention.
One question about the nutrition. So the reason they eat the reason they don't eat that much vegetable, I guess, is the cost. Are you helping them with that? Vegetables are expensive.
It's partly cost, but it's also partly about knowledge. There are some greens and vegetables that are grown locally, which they think are weeds, and they're available freely. And because they don't have to pay for it and they're available freely, they think they have very low nutritive value.
Okay.
So part of our discussion with them is actually about pointing these things to them and sort of guiding them towards making use of these easily available nutritious foods.
And the protein aspect, the dal?
Dal is a bit more difficult. We had a big debate about whether we should actually be supplementing them with proteins and calories as well.
Yeah.
And we decided we wouldn't, because A, it was going to be very complex, B, it was going to be very expensive. And we had some people in our group who strongly felt we should not be giving them a product. We should be trying to do this through diet diversity and foods, and even the multiple micronutrients. We had to put a lot of thought into whether we should actually give it or not.
Right. And the fact that their staple is ragi and not rice, is that a positive in your view?
I mean, they eat rice as well, but ragi is the main staple.
So that's healthier, I guess. I don't know.
Yeah.
Okay, thanks.
One question. Considering the diversity of Indian population in culture, geography, and dietary patterns, I was just thinking why only Mysore was chosen for recruiting the participants to draw a general conclusion about Indian population.
You're making a very good point. I mean, it was just the practicalities of being able to run such a large study from multiple sites. So when originally we were funded, DBT wanted us to run this from multiple sites, and it just wasn't possible. Running a study in one site like this is complex enough. There was no way we could have done it across multiple sites. And by and large, this rural population in transition, although the exact site-specific issues might be slightly different, let's say to a village in Western India or Northern India, by and large, the population is representative of rural India who are making this rapid transition into into a different lifestyle. Diets are changing, they are becoming more energy dense, there's lower levels of physical activity. So all those aspects are probably going to be common across much of rural India.
If I may add to that point. So it is also, since this is a randomized controlled trial, we are more, of course, representativeness is important, but we are more concerned about the relative efficacy of having this versus not. That takes priority over representativeness of this one in terms of interpretation.
Sorry, we're interrupting you, but maybe you have it
problem.
in your next slide. So when you're doing a multi-country study like this, and you've used 2 cluster randomized designs and 1 individual randomization, just wanted to understand the plan of analysis when you're going to harmonize across 4 centers, number 1. Number 2, the question on the intervention being adapted to site. So would you have enough samples power in each site to be able to answer that question, or it will only be with the harmonization? Because your intervention is fairly variable, which is okay, I mean, which is understood, but I just wanted clarity on that. I'm sure you have it there.
No, I actually don't have it on the slide, but I'll answer the second question first because it's easier. The studies are all individually powered. So each of the 4 studies are individually powered to achieve the outcome. Your question in terms of pooling the data finally is very valid. We are still struggling to see how we will actually be able to pool individual level data across the 4 sites. What our tentative analysis plan at the moment is to actually pool summary data, because our argument will be that we are all addressing the same domains. Nobody is addressing it in a different way, although the way we are actually doing it is site specific, but we are all addressing common domains. We are all collecting data in a similar way. We are looking at similar outcomes. So in that sense, we hope to be able to pool data in the future. And that was part of the reason for HEALTH being set up, with the idea that we could pool this data across 4 different countries in 4 different settings so that it would have a bit more of a global impact. But again, something like this has never been done before, so we are all learning as we go. And if you talk to purists, pool data, but if you talk to purists in clinical trials who do only RCTs for a living, they don't like this design. They don't like the design, they don't like the analysis, because we are not going to be able to tease out the effects of individual components of the intervention. I'm hoping we might be able to do that with advances in machine learning and artificial intelligence, where we might be able to say, okay, so maybe giving the micronutrient supplements had a bit more effect on BMI or something like that. But it's not a factorial design. So teasing out the effects of individual interventions is going to be very difficult. All we can say is that this suite of interventions may work or may not work. You had a question, sorry.
Yeah, this question might be answered in a retrospective manner. So in the preconception phase, the intervention that you did was typically how long before the preconception? And since diet and nutrition has a time scale over it, it starts making an effect. So do you get an idea about those time scales also?
So we continue these interventions in a cyclical manner. So the modules get repeated for a maximum of 18 months.
This is for preconception.
For the preconception.
Okay.
So they either become pregnant by that period, in which case they move into the pregnancy phase,
Right.
or if they don't become pregnant between 18 and 24 months, they then exit the study and we do an exit assessment.
I see, okay.
So that will be a separate cohort that we hope to follow up later. Any other questions at this stage?
Fantastic cohort, and I think the interventions are, so we did something for Dr. Chitran and Yagnik, where we basically looked at the analysis of over 18 years of age, and we see that there's some nonlinear relationships between HOMA beta and HOMA S. This is the next step where you're introducing interventions and probably looking at that kind of metabolic data also. Are you considering the effect of possible interactions between interventions themselves and developing a causal model towards that effect?
There are plans to do all that. I mean, I'm no expert in the that kind of statistical modeling and analysis. But yes, we have people on our team who will be able to do that. And we'll certainly look at the effects of interaction. For example, one of the things that we are very interested in is the effect on sex, whether these interventions actually have different effects on male babies and female babies. And in India, we are particularly powered. We've got almost 80% power to be able to look at sex-specific differences. So sex is an interaction that we'll certainly look at as other.
I'm saying just because we see that there is a nonlinearity of effect over a longitudinal period of a very long time. So it may be interesting to actually incorporate or see if machine learning, we, for example, work on Bayesian contextual learning as well. So essentially, if that kind of approach captures some nonlinearities, that was not otherwise accounted for in the model.
It'll be very helpful to talk with you later.
So, well, I may be wrong. You have a follow-up of the infants till 2 years.
No, at the moment till 5 years.
5 years. And you're doing a neurodevelopment assessment at the end of 2 years?
2 years and 5 years.
Okay. And you're doing the full, the conventional one or the new GSED WHO?
It's a good question. When we started the study, we were planning to do DASI. Sorry?
Not Bailey.
No, DASI is the Indian adaptation of Bailey, right?
Yeah.
I mean, Mom, with my
yeah.
name,
Fine.
with my very limited, no, but because of the harmonization, and now that GSED has actually come out, we are all planning to shift to GSED.
Okay.
So all the study sites will do GSET.
So just a suggestion, because the GSET Indian contribution is being done now. It will start now. So maybe that discussion. And the second question, sorry, for this is, well, how are you defining metabolic fitness in children?
It's at 5 years, we are planning to do glucose tolerance tests. So hopefully we'll have data on glucose insulin. We've done 5-year GTTs before in Mysore. So we are hopeful we'll get reasonable compliance for that. And then blood pressure, of course. So some of the challenges we have faced as a consortium has been COVID, of course. COVID had a major impact on us. Our study was going to launch a recruitment in April 2020. And then, of course, end of March, we went into a shutdown. So it sort of delayed our timelines by almost a year. So it's had an impact on recruitment, our progress, as it has had on South Africa and China and all the other sites. The long follow-up period, and so retention is an issue for us. We're working very hard to try and retain those we recruit, but a 10-year follow-up is a long study. The participants invest a lot of their time and effort into this. So that is a challenge, and we've got to try and maintain our retention rates as high as possible. We've got a retention strategy that we are trying to implement across the sites, and I'll come to that in a minute. But fatigue and retention in such a large study is an issue. We have allowed for fairly comfortable attrition rates, but who knows, we are still in the early stages and these things can change. The storage and maintenance of biospecimens and the infrastructure for the biorepository is an issue. When we all started this study 3, 4, 5 years ago, we were anticipating to collect about between 5 and 7 aliquots per participants. Over a period of time, this has now grown to 21 aliquots just for the preconceptional phase alone. So this has huge implications for us in terms of resources and infrastructure. And then finally, the issues around data sharing and access. This is again an issue because India has very strict data sharing guidelines. China has their own. South Africa has their own. So how we are going to make this work in the future? The positive thing is this is being funded by 4 national funding agencies. So there's a will to make data sharing happen. At the moment, the idea is that we use the system called Maelstrom and Data Shield, where data sits in the individual country servers. It doesn't, individual level data isn't sent out of the country, but the other researchers can actually access this data while it's sitting within our servers, but pool data at the moment. So that's where we are at the moment. We have a governance framework under data sharing and access framework, which is which has been accepted by all the 4 funding agencies. And hopefully we'll be able to make progress on this over the next couple of years or so. Some of the local challenges we have had, the main one is the extended recruitment period and retention. We had to slow down our study at various stages because of COVID, because of other issues, because of funding issues, infrastructure, etc., etc. And all our baseline data collection is done in the field. So we had to set up a mobile lab that would allow us to collect blood specimens in the field, process them, put them in dry ice, and then bring them back to the hospital for storage. And we had only 1 lab. So that was a bottleneck for us. So we then discovered that a lot of the women were going out of the area for deliveries. So we weren't able to follow them up as much as we would have liked to. So we're now trying to see how we can address that by either recruiting more staff or sending staff out of area to actually recruit them. Otherwise, we have to rely on birth records, which is not always ideal. We would like to collect our own data. There's an implication if we are not able to speed up our things and collect baseline data collection, particularly the bloods on time. We are able to do the questionnaires over the phone, but the anthropometry and the blood obviously has to be done face to face. And if we can't get that done in time and the woman actually becomes pregnant, then we have lost that phase where we can actually collect the baseline data. So that again is an issue that we are trying to address. The intervention delivery, we had always planned on doing it in small groups. And that was based on previous work and literature where there seemed to be some strength with women getting together in peer groups. And we thought that would be one of the strengths of our intervention, but obviously COVID put a stop to that. So we started delivering the intervention one-to-one. We are now slowly scaling up to group level again. But that again has implications both for resources, but also, we don't know whether the individual intervention might actually be more effective or less effective than the group intervention. And since COVID, we have had huge turnover of staff. We lost almost all of our field staff during the COVID period. Their families, we recruited all of our staff from the local area. So these are all local health workers who are based and live within the community that we are working in. That was a strength. But on the other hand, it also meant their families didn't want them to go during COVID. We lost them. We had to recruit again, retrain, etc., etc. And then getting truly informed consent for these kind of long-term studies in such settings is difficult. We have a very good rapport with the local community, and it's almost done on trust. So in a way, it puts extra burden or onus on the researchers to make sure that we are not exploiting the participants, because they say, oh yes, we worked with you for 30 years. It's okay, we'll sign this. And we've got to be very careful that we try and make this as fair as possible. So some of the strategies that we've used, we've got video community engagement meetings, as I've mentioned. We have a radio station. So our hospital has a community radio station which actually broadcasts health and social care programs for about 14 hours a day. It started with 2 hours a few years ago. We've now increased it to 14 hours a day. So we use that as a tool to keep in touch, to give updates, etc. And then we participate in all the village fairs, events. And if they have health issues, they can come to the hospital. So we act as the first point of contact for any health issues. So those kind of things continuously to try and keep the engagement levels up and to make our retention rates as high as possible. So this is what we have learned. These developing protocols for such long-term community-based studies is complex. And starting preconceptionally actually adds an extra layer of complexity. We had to try and get a balance between the hard science and the local socio-cultural context. And the community engagement buy-in was essential. We could not have done it without this. So this is just progress. South Africa started about 2 years earlier than the other sites, and they've completed their recruitment. China is 3/4 of the way through. We are just less than halfway through. And Canada had some issues, so they're still about 1/4 of the way through. So all of the sites have got fairly good levels of data collection at baseline, the adherence to intervention, and the funding is basically to deliver the intervention. For anything else, we had to seek additional funding. So we've all got additional funding for a number of projects. So in India, for example, we're collecting the biospecimens. The grant funds us to collect the biospecimens, but we don't have funds for analysis. So we have to go elsewhere and seek additional funds to actually be able to use all the data that we are collecting. Sorry? I know. So we've got a couple of grants now in India to do some inflammatory markers, to do some measurements on body composition using stable isotopes, etc., etc. So each site, some of these are collaborative projects across the sites, and some of these are individual. So why do we think health is unique? I mean, this is an international program that is hopefully addressing a global challenge. The a priori harmonization, I think, is a big strength. We've got 4 different sites in 4 different countries, different stages of transition, but highly harmonized in terms of data collection, the domains of intervention we are targeting, the tools we are using. The concept of integrated intervention, starting preconceptionally and going on until childhood. We've got a very strong governance framework, and we think it can have a major impact right from public health policy through to systems biology. And it offers a unique platform to leverage all these resources by developing collaborations. And so that's what, anybody here who's interested in collaborating with us, please reach out. We're very open to collaborations as a consortium. The principles of open access and collaboration have been paramount to the Healthy Consortium right from the inception. And we have a draft governance framework which has now been approved by all the 4 funding agencies. And these are just examples of some of the opportunities that exist. We will end up with a huge biorepository in a few years' time. So there's opportunities to undertake a host of mechanistic studies to understand fetal and intergenerational programming. We'll have biomarkers and phenotypes for markers of maternal outcomes, child outcomes. We'll have data for maternal and paternal health because we are collecting data on both the mothers and the fathers. A lot of data on early childhood development, socio-cultural context, economic evaluations. So the potential is there. And it's up to us as healthy investigators to make sure that we leverage this data and make the best use of this. Just thanks to the teams. This is our international team who came to Mysore just before COVID, because we have an annual meeting at a different site each year, and this is our local team. Thanks.
We do have time for questions.
Thank you. Actually, it again emphasizes what we discussed with our younger colleagues here, that collection of data and the right quality and is so important, and one can see the challenges that one faces. The other thing, when you talked about national collaborations, it would be very important because there are many cohorts like we have in the north and other. It would be important particularly to take up for some public health diseases where the outcome is not what you may be measuring, but identify like stillbirth, for example, those kind of outcomes where these cohorts can actually be harmonized and national level. It's not just about global harmonization, it's also the national level harmonization of cohorts, which now has become absolutely essential.
I think it's a very good point, and I don't think we do that well enough. I think we are all just so busy working in our own silos and trying to get our own projects off the ground and running that I don't think we talk enough to each other, particularly within, you've got your huge cohort, there's the Wings cohort, there's ours here. And, there's very little real interaction between us. Yes, we meet at meetings and we all know each other and get on with each other, but there's no real joint work actually taking place. And I think it's a point well taken.
Gautam and then Tap.
I was at a meeting yesterday where some part of the discussion was about how to disentangle the COVID effects in the long term in studies of this sort. And the general consensus was that it is very hard to do and practically impossible. So even when you try to harmonize across, especially different countries where the experience of COVID impact, for example, people falling into poverty as a consequence of COVID and changes in diet further, that makes it far more complicated to analyze. I was just wondering whether you had thought about this or whether this was an ongoing discussion in this collaboration.
So each of the 4 sites undertook a COVID surveillance. So we actually collected data on our participants who had been diagnosed with COVID. I'm not sure about the quality of that particular information because in this community, there was a lot of reluctance and reluctance to actually admit to having COVID. So what we found out during COVID was that the villages basically barricaded themselves. They didn't let their village members leave the village, nor did they allow any outsiders in. And so when we did our initial survey, when COVID rates in Mysore were reasonably high, we didn't have a single positive. We didn't have any participant who actually admitted to have had COVID. So I don't trust our COVID data. But in terms of the impact of COVID, as you said, I think it's very difficult to really adjust for it or account for it because the way it affected us was quite different to the way it affected South Africa, way it affected China. So what we have done is try and document as much of the changes that have taken place as possible because of COVID. Now, how we are actually going to use that and whether it's really in a usable format, I don't really know at this stage.
Tap.
Thank you, Kumaran. So My question is about the para data. So I know it's difficult to collect data across sites, across countries, when there's so different settings. So how well is can you give a sense of what are the kind of para data that may be collected? The context to this question is, we worked with the organization called Swasti based in Bangalore, 5 different southern Indian states, where we looked at 15 years data on HIV transmission in sex workers. Question being, what mitigates HIV transmissions in these sex workers? We did not imagine what may come up later in the Bayesian contextual AI analysis, and financial access to financial information for these women came out to be the most consistently happening factor. Initially, we thought it was an AI sort of a bug, but then the organization tells us that the more empowered a woman is financially, the more empowered they are to say no to unprotected sex. We did not imagine that in the first place. So how strong are the paradata that may also be interventions of some sorts going down the line? And have you thought about those kind of data sets that can be also made a part of the analysis?
Just give me an example of what type of paradata.
So for example, these pregnant women, do they have a bank account? Do they have an independent bank account? That's from the and that work was published in Europe's.
So he's asking, asking the unmeasurable factors that influence.
We've got a list of items on which we are collecting data across the 4 sites. So we're collecting, for example, so education, for example. So each site is collecting data on education based on the years of schooling. So hopefully that will be it'll be comparable. And so we are not asking for qualifications, we're just asking for years of schooling.
Right.
Similarly, there's a socio-economic status questionnaire that we use. Of course, the one we use in India is called SLI, as you know, but each of the countries are using a different one. So what we're planning to do is we'll end up with a summary score for SLI. Each of the sites will end up with a summary score for their own socio-demographic status.
Right.
Now, how comparable that will be, we don't know, but each of us will end up with one summary score for SLI, which will hopefully allow us to make some kind of comparison. Even if it's not the actual value, we can look at the order.
What I'm trying to come to is, can we measure how much agency does a woman have in all of this? So
to some extent, yes, because we've got some information on diet, on education, income, household income, as well as the individual income of the woman. We've got some information on what type of fuel they use, whether they're employed, not employed. If employed, what kind of, is it self-employment? Is it working for somebody else? So there is a range of things we are collecting. How we are going to use that, I don't know.
Thank you.
Great. Okay, there's one last question.
Sir, so you have multiple outcomes and multiple combination of the exposures, and those outcomes in a multiple stages of the trial. So is your sample size is static, or it's dynamic based on the evidences you are getting over the time?
Again, a very good question. Our sample size, we have calculated the sample size only for our primary outcome, which is fat mass index at 5 years of age.
Okay.
So that's the only thing for which we have actually calculated a sample size. We have had huge arguments about this with some of the purists in our team, the classical trialists and the statisticians who say, because you're unblinding at phases, you should actually have a sample size for each phase calculations. We said, no, it doesn't make sense for us to do a sample size calculation for each phase. We'll stick to the sample size calculation that we have for the primary outcome.
Okay.
Then for all the other outcomes, the number is what it is.
Thank you, sir. I will go back and read your study in detail. Thank you.
Thank you.
Great. I think in the interest of time, we should close. Dr. Kumaran is around for the entire afternoon, so please feel free to reach out. Thank you again, Kumaran, for sharing the data. I think it highlights the fact that we do need to work together. We do need to put the cohorts together. And there is hopefully for the early career researchers here, there's a huge opportunities exist in terms of clinical data. We need to reach out, we need to work together, and hopefully that makes us stronger. Thank you again, Kumaran.
Thank you.